medication for you.
Last week, Susan asked me if I would put a medication on the board every week or every day. The medication that's up there is specific. It's good for pneumonia, but it came from the chapter on anti-infectives, and I looked at it with respect to upper respiratory infections. It's like Suboxone. Okay, look. Delete this. Cephalosporins. Cephalosporins. I'm not going to talk about those too much because I talked about them a little bit the other day. But I think on Thursday we'll put the one up there. We're going to do just a little bit of chapter 41. Okay? Got your PowerPoint? Did I give everybody a copy? No? Yeah. Okay. Did I give me a copy? No.
There's extras up there.
Where are they?
In the middle of the table. Are they not?
Yeah. Everybody get one? Thank you. I have trouble finding things at the end of the day. Delete. Okay. Let's talk about drugs for the lower respiratory. Now, you're going to be covering COPD on Thursday.
All right, we'll start in a minute and a half. Yeah.
Okay? What's that now?
I said I'm starting in a minute and a half in. This is when I'm making a note to myself.
Okay, yeah,
to start in a minute and a half in to when I started recording.
No joking. That emotional stuff I looked earlier.
That was not, the camera was off.
You better watch
It was not, I promise.
Let's talk about COPD. As I said, we'll be talking about this at length ad nauseum on Thursday. What? I beg pardon? This is 41. Yeah, this is 41. Chronic obstructive pulmonary disease. What do we mean by obstructive pulmonary disease?
Airways are constricted.
Airways are constricted, or we've got a problem with compliance, or for whatever happened, gas exchange is not happening the way it needs to happen. We've got some sort of obstructive thing, whether it's because the bronchioles don't dilate the way they're supposed to, expand and contract, or whether we've actually got something in there. Is it mucus? Is it lack of alveoli? That's what chronic obstructive pulmonary disease. And then we also have asthma falls into the category of chronic obstructive diseases. With asthma, we have an inflammatory airway obstruction. How many of you have heard wheezes? Now, okay, did you do the tutorial from chapter 21? Everybody in here, you need to know those tutorials in chapter 21 are very important. And you will probably see that material again, if not this time, at some point you'll see it. Okay? Those are very good tutorials, and they've got some real good lung sounds in there. So wheezing is a whistle, real high-pitched whistle. Okay, and you can hear it in the upper lung fields and the lower lung fields. And it can be very soft and very faint, or it can be quite loud. And the louder it is, the more obstruction you've got. What happens is stimuli cause the bronchioles to become inflamed and edematous. And that stimuli can be an allergen. It can be something within an iatrogenic. It can be a chemical. It can be an infective process. Or it can be an I don't know. We don't know why some people get asthma. Bronchiectasis is an abnormal dilation of the bronchi and bronchioles. If you have someone who's got frequent infections, they're more prone to get bronchiectasis. Remember, this is the pharmacology book, because we're going to be talking about some pharmacodynamics in a few minutes. Don't get too hung up on all of this, because we'll talk about it more on Thursday. What happens with bronchiectasis is when we're talking about, who's asking about the embolus a few minutes ago? Infective, okay. What can happen with bronchiectasis is that you have mucus and cells dying in the bronchioles, or the bronchioles, and they break loose, and they just form this tissue that's just kind of sitting there, and it can block the alveoli, or block the bronchioles, okay? And then you have emphysema, which is progressive. What happens with emphysema is that over time, the alveoli merge. And instead of having millions and millions of little tiny alveoli perfectly there, ready to absorb gases and exchange gases, you have clumps of alveolar tissue. And remember, it's going to be a whole lot harder to get the air in here than it is in these little tiny discrete alveoli. Now, emphysema can either be progressive due to chemicals like smoking. There are some individuals who are missing an enzyme. And I don't know at what age this happens, but they don't have alpha antitrypsin protein. So the terminal bronchioles get plugged, and the end result is alveolar collapse. They collapse and they just kind of morph, and they don't work anymore.
Is that in smokers?
Smokers and also, yes. The end result of any emphysema is alveolar collapse. So if we have clients who have COPD, we want to open the passageways. We have 4 or 5 major classifications of medications that we use. The first are bronchodilators. We want to open the airway. Okay? And they are sympathomimetic. What do we mean by what happens with the sympathetic nervous system's activated? When we're running from the tiger, what happens? Bronchioles dilate, okay? Because we want lots of air in there because we've got to get away because he's getting ready to eat us. Okay? They are parasympatholytic. So what do we mean by something that is lytic of the parasympathetic? Shuts down the parasympathetic, right. Right. Which makes them anticholinergic because remember acetylcholine is the primary nerve transmitter for the parasympathetic nervous system. So what are the primary transmitters for the sympathetic nervous system? Epinephrine and norepinephrine, right. And what do epinephrine and norepinephrine do in addition to dilating the bronchioles? They increase the heart rate. Okay? So what do you think a bronchodilator might do? Increase the heart rate. Okay? We also have the methylxanthines, which are coffee and theophylline. Okay? And these are all bronchodilators. We use glucocorticoids because what does cortisol do? It decreases inflammation. Okay? When we have high levels of serum cortisol, what do we also have? Stress. We have stress, but what happens? Sugar. Okay, glucocorticoids raise our blood sugar, right? Because when we're running from the tiger, we need that sugar. Okay? Our muscles need it. So a glucocorticoid might be likely to do what to a person who's on them long term?
Weight gain.
Cause diabetes. Okay? Elevated blood sugar. Okay? Then we have leukotriene modifiers. And leukotrienes are chemical mediators. And they stabilize the mast cells, basically. Mast cells cause histamine release and cause all that inflammation. So the leukotriene modifiers decrease that inflammatory process. And then we have expectorants, which we know loosen mucus. And what's the best expectorant? Water, hydration. And of course, if we get an infection, then we use them to treat patients with antibiotics. So these are the 5 major classifications of medications that are going to be used specifically with COPD. We want to dilate the bronchioles. We want to reduce the inflammation. We want to stop the process. We want to help the clients clear the secretions that are there. And if they get infected, we want to give them antibiotics.